Welcome back, Smile Mentor family. Matt Griffin here, the Smile Mentor. In today's video, we are interviewing another key All-On expert, and that is Dr. Tadros, who works with Dr. Salama there in Atlanta. And he is a prosthodontist that is pretty good on the lab side of things too. He took time to really talk to us about the different materials, about the guided surgery and the need for guided surgery, technology, and even showing us throughout their lab there at the clinic. So I think you guys are going to enjoy Dr. Tadros. It was unexpected to get to interview him, but man, I'm glad we did. He brought in a whole nother perspective on the digital side of things and digital dentistry. I think you guys are going to find interesting, and we'll give you some questions to ask in the future of any other experts that you're going to go be and see for your mouth or any of your work. So thank you guys. I appreciate you guys following. If you have not subscribed, please do. And any questions, please read in the description below. You'll find out more about us. Have a blessed day, guys. Thank you. Dr. Tadros, glad to meet you for the first time.
Thanks for having me here. I really would be very happy to answer all your questions that you want to ask. So let's see what you have here.
Yeah, absolutely. Let's start off. Can you give me a brief history of yourself? Tell me a little bit about
So
yourself.
I actually graduated from Augusta University, 2 hours south of here from Atlanta. And it's basically the only dental school in Georgia, and one of the top schools, actually, especially clinically. I think it's top 7 or so. And after graduation of the dental school, I figured I wanted to do more than just filling and drilling or, making crowns. So I ended up wanting to do the full mouth rehabilitations, because that was something that we were frowned upon from doing in dental school. That was the big no-no. It was only for those who knows how to do it. So that made me want to learn how to do it, because I felt like that there was a secret behind it of how to do it correctly. Luckily, I had a mentor in prosthodontics. His name is Dr. Gerard Chiche, that I was able to shadow during my senior year. And once I shadowed him, I saw what they were able to do, the full mouth rehabilitation, the All-On-4, All-On-6. And I was very impressed by the result and the quality. He's a French doctor, very high-end for aesthetics and quality of work. So I ended up shadowing them so much that they actually told me, why don't you be part of our program if you have the right grades? So I luckily had the right grades. I applied. I got into the school, the same school. I spent 3 years there, which was specialty program in prosthodontics. So basically a prosthodontist is an overly trained dentist on how to do full mouth rehabilitation and complex treatments that you don't get to do in dental school. And it's 3 years of a lot of work. Mentally, you're always challenged with cases with patients that might have had cancer, and you have to restore them. So emotionally, it could be a lot on you as well. And we had to do all of our lab work. So as dentists during the residency, we didn't send anything out. We actually had to sit down after 5 o'clock, do all the lab work for our patients. So we got to learn the perspective of how the lab should do things and how should we communicate with the lab to be able to give us the quality that we want. And that actually made me, after graduation, I got in with Dr. Salama, and that made me want to start my own lab. So I started my own All-On-X lab. I have it's a lab that actually creates All-On-X prosthesis for other doctors. Yeah. And it's actually here in our office. So we have 2 labs, Salama's lab. And then when we do All-On-X cases in this office, they go through my lab, because I was very interested in knowing how the process should be done correctly. So just as yourself, you wanted to know more about All-On-X, what's the best questions to ask and all that. I wanted the best quality, not quantity. And that's part of why I joined the team here, because I have the surgeon, I have the best mentors, Dr. Goldstein, Dr. Garber, and Salama. So mixing pros with the perfect surgeon is a huge combo. So that's why most of the well-partnered offices is usually either a periodontist with a prosthodontist or an oral surgeon with a prosthodontist. So the prosthodontist is the core of the final restoration, and the surgeon is the core of making sure everything surgically goes right, mixing them correctly. I think it's a huge deal.
Yeah.
So, yeah.
I mean, fresh from out of school, you came here, and yet, I mean, that's a big deal because I know they're not just going to hire anybody. So you must have done pretty well.
So in 2014, when I graduated dental school, I had $3,500 in my account, and I was actually going to start getting paid in the residency. It was like $1,500 a month, which is really amazing. From having to pay student debts, now I'm making $1,500 a month. I decided I wanted to buy a 3D printer, not for dental usage. I was always into designing things on the computer and wanting to like create the parts digitally.
Okay.
So I bought this printer in June of 2014. It was Form 1 Plus. Since then, I've been into 3D printing since 2014. I started teaching about 3D printing in dentistry in 2015. Actually, I used that printer to make things that I could use in dentistry, not final restorations, but trying dentures, surgical guides, and so on. It was in the very early stages of how 3D printing got into dentistry because I don't know if you know or not, but the patents of 3D printing ran out in 2012. So from 2012 to 2014, that only was 2 years for it to start to merge into dentistry and be affordable. So with $3,500 printer, I was able to do things that I could never imagine, but that required that I actually learn how to design. Because even at that point, nobody knew how to design correctly. So as I was doing the lab work after 5 o'clock with the manual analog labor work, I was also doing it on the computer. So I had to do it both ways because our residency would not accept digital.
What great training though.
So the training in the residency was on the fundamentals. I took the fundamentals and I tried to figure it out digitally. And our school in the beginning was against digital, but now they're very into much digital. So
you were ahead of your time.
I was. And Dr. Salama, main thing about bringing me here was actually to move the office digitally. And that's what we did here. So that's why I wanted to make a lab that's digital. At one point, I think we had over 8 or 10 printers next to each other. Right now we have, I think, 6. And at our office, we do a lot of prototyping with 3D printing. In fact, I brought some to show you.
Let's what I'd love to do is if you can kind of show, because this is stuff that most patients, I've gotten to see some of this again doing what I do, but most patients don't get to see this. So can you walk through the journey on what actually takes place from the beginning? I think you even have a puck or...
Yeah, so when patients come in, the first thing I like to do personally, and everybody in the office like to do, is to scan the patient intraorally. We have multiple intraoral scanners in the office from different brands, and we actually have a digital scan on the computer of their current situation in color. So we can move the teeth around, we can show the patient the situation that they currently have, and on the computer mention exactly where we need to fix things. From there, the patient gets a first perspective view in their mouth, but on a big screen, which is really a wow factor. From there, we explain to the patient the treatment plan on model work. We do everything in this office guided. So everything is surgically guided from a single implant to an All-On-X case. Every single All-On-4, All-On-6 is guided. We don't freehand anything in this office.
Why? Tell me that, because I mean, I've worked with some offices that do both. They'll do some freehand and some guided, but you're saying all guided here with this
Everything
team.
is guided.
That shocks me, not because I'd just be curious why.
Okay, so that's a very good question. So no matter how many years of experience you have, a free-handed surgery could be off a few degrees from where I want my exact screw channel of how I can create a prosthesis that can have all the screws coming in exactly in the center of the teeth or exactly in the lingual, which is very important because once the screw come out of the outside of the tooth, that creates a problem for us as a restorative dentist. So it's really nice to work with a very open-minded surgeon like Dr. Salama, who has over 27 plus years of free-handing surgeries, to all of a sudden say, okay, let's do everything guided because it makes sure that everything for the patient is as perfect as it could be. It's It's basically like if I tell you I can get the implant within 2 or 3% off angle every single time versus I could be off by 20 degrees if I freehand it, that's a huge difference.
Big difference.
So we just care for accuracy, and we have the ability to do it. Not every office has the ability to do it. So a lot of offices will send out to a lab to have a surgical guide done, and that could take time. And sometimes you don't have the time. The patient wants to move forward with the surgery, and it might not be feasible. Sometimes it could be an extra expense on the patient. We don't actually, usually charge extra for that part.
Right.
So it's part of our all-inclusive treatment plan price for our patient. And it's really just to try to get the best quality result for them. We know where the exact depth of each implant is, which is very important for the thickness of our prosthesis, because if we make it too thin, it can break. If we make it too thick, we're gonna remove more bone than we're supposed to. So we actually design the entire implant process of the surgery on the computer, on the patient CBCT, and then we transfer almost 98% with accuracy to the patient. And the way we do that is we 3D print everything. So this is a surgical guide. As you can see here, the holes is exactly where the drills go. This actually gets fitted on top of another part. Everything is super fit. They click into each other. And this whole part sits on the patient bone after we do a flap. And we know the exact direction of the implant angulation and the depth. Once this is completed, we take this part out, and then we're able to put the teeth in, which in this case, this is a clear one just to pick up, but we also are able to print them or mill them in actual hard material that the patient can keep for over 6 months. So we usually have our patients in the healing process for 3 months. And then after 3 months, we transfer the patient from a temporary that they have after surgery to another set of temp with perfection. So
PMMAs?
Yes, 2 PMMAs. So the day of surgery, our patient gets 1 PMMA. And then 3 months later, we make another PMMA. This new PMMA mimics the final, but it's much more improved than the surgical one.
How?
So aesthetics could be better. If we have a little cant, if we are within 2 degrees off, we correct everything. We're very particular about these things. So we have a studio, we take a lot of photos. We put a lot of lines, vertical and horizontal lines on the patient face. And we figure out, are our teeth aligned together on both sides? Is it canted? Is it off? And if so, we correct the occlusion and everything. Also, many times, right after surgery, we don't give the patient the same bite after surgery as we do in the final. So right after surgery, the bite is more flat. We don't want the patient to have walls that they're chewing against, like natural teeth. So the teeth are more flat. The bite surface is more flat. That's to put less forces on the implants. Okay, because if the patient is going to start
dispersing the weight and the pressure so that instead of them being more central, so now it's more spread out.
Exactly. So natural teeth fit into each other like a machine. On a surgically temp patient after surgery, the teeth are more flat on the bite surfaces. That allows the patient to slide more freely than actually putting a lot of pressure on the patient implants, which could cause failure. So that surgical temp does not actually mimic the same bite as the next temp. The next temp, the patient actually gets a more of a natural bite where the upper and lower teeth fit much better together and the patient can chew better. So there is an efficiency gained in the second set of temp.
Okay.
From there, if the patient accepts our temp and they like everything about it, we actually, because we're digital, we can copy the temp 100% into final. And most people don't understand how can we do it 100%. Because we do everything digital, we actually have the temp that we did, digital copy of it. Instead of milling it into a PMMA material, we just send it to another machine and mill it into a Zirconia material, which comes out of the solid puck.
Okay.
This is Zirconia. Zirconia does come in different strength, different qualities. So we choose the highest quality. We use couple of different brands that we like with different translucency. So we've tested many different Zirconias, and there's few that we like to work with, and all of our patients seems to like these ones. A lot of problems with zirconia is the fact that it could be opaque, and a lot of people don't know how to deal with it. It's a very difficult material to deal with because if it wasn't milled correctly, or if it goes into the oven to change to the right color, because right now you see it in the white chalky stage, which is called the green stage. It has to go in an oven at almost 1700 degrees or 1500 something degrees for over 8 hours to even 24 hours. And from there, it actually changes to the right color. The problem is the color sometimes is opaque, and a lot of ceramists, when you talk about lab, they will have to blend in some staining and coloring over there, which actually sometimes could break the zirconia. So our zirconia is monolithic, meaning it's one piece. The only thing that we add on is the gum. Our teeth is multi-shaded built into the zirconia. And a lot of times when we do the add-ons, this is how it looks after we stain just a little bit and add the pink gum. And you can see this side has no staining or anything like that.
Dr. Tadros, if you could pause for
Yeah.
a second. Just to give you guys a heads up, all the background noise, Dr. Tadros has been awesome in the fact that he's staying late to do this for us. We have Dr. Salama. We had a great interview. He had patience. We had to get delayed in getting started on this. So it is 7:35 at night. And so again, any unique sounds you hear in the background, that's not Dan dancing or anything like that. Just wanted to give you guys a heads up, and so that you guys cut us a little slack, because we're pretty sensitive on any sounds in the background, but we got to deal with it today. So again, sorry about that, but here we go. So
do you want me to ask them to?
No, it's
okay.
fine. It's fine. Well,
Okay.
you know, we've now embraced it, and so you
Excellent.
know what I mean. So now you've shown us the half and half. What does zirconia break?
When does it break?
Yeah.
Most of the time it breaks on fast cooling. The problem with zirconia is it needs to go in the oven for a few hours and to be colored. And after it's colored, it takes almost 2 hours to cool down. And a lot of ceramists and a lot of labs, they try to do the process a little bit quicker. Instead of waiting the hour and a half or 2 hours, they will wait just 45 minutes and cool it quicker. And that can create internal cracks. And the problem with that, it could break right when I'm delivering it. So
really?
It looks
That
great.
quick?
Yes. It could actually look great when I have it in my hand, but as soon as I screw it in, it cracks all the way through. If it passes the test and it goes into the patient mouth with no cracks, you're good. But a lot of times it can actually crack in shipments if it already has an internal crack that you're not seeing. So one of the best tests that we do is actually hold it against the light and see through and see if there are any internal cracks that we're missing. Another thing, when you design zirconia, there is minimum thickness to it. That's why we plan everything on the computer. You were asking, why do you digitally plan everything and why do you guide everything? We like our zirconia to have a specific minimum thickness vertically and in width, which actually give it strength. And from our research that we have, we found that we have very minimal problems. In fact, since the last 3 years, I've only had one crack. So this is why I wanted to start my lab here at the office, is because we wanted full control over quality and speed. So we can have zirconia done in less than a week from start to end. We can mill it, stain it, and deliver it in less than a week. Some people,
that's fast. Yeah,
but some people do it in 24 hours to 48 hours, which that's when I'm thinking,
cutting corners.
Mm-hmm. So it's very important. Also, some people, I see, especially in social media, something that's disturbing sometimes, in my opinion, which is over removal of the bone, over reduction of bone.
Oh my gosh.
So, and some of these clinics are very successful. And it's because I know it can be done in a different way, which is more conservative. It kind of breaks my heart sometimes to see it. So Dr. Salama and I actually already published last year or a year and a half ago about the scallop design. Excuse me, sorry.
That's all right.
So the scallop design is, instead of us cutting the bone flat and removing excess bone that we can save, we actually scallop the bone to create the same architect as the tooth margin, which actually reduces bone reduction and also looks more natural. Yeah, I can show you a case on the computer if you want to record it. But this actually is a proof of that concept. So if you want to see this, this is pretty impressive actually. So instead of us doing...
So how many okay, so are you at 8 millimeters, 5 millimeters, 10 millimeters? What is your average? And I know it sounds like each one's custom, but how
so
much?
Depending on the implant positions and how many Pontics we have and how many cantilever teeth we have, the numbers do change. They can range anywhere between 10 to 14 millimeters.
Okay.
Minimum, I would say 8 to 9. Also, the bite change. The bite scheme actually change if we have thinner zirconias. We reduce bite forces. So there's so many factors that most people don't even really realize. And that was my main interest back in school, is actually treating All-On-X patients. So I call it All-On-X because we don't go for All-On-4. Minimum All-On-6. If we can fit 8, that's even better. We always over-engineer the process. In case you have 1 failed, 2 failed, you can still keep going. So this is very interesting right here. So this is a scalloped bone right here. And this scalping was actually done by this surgical guide right here, as you can see there. And the scalloping of the bone matches our prefabricated design that we have before surgery. So this fits right on after we place the implants, which the implants are also guided using this guide right here, which all of these guides we created in the office and printed them here. So we make our own guides and everything. So this guide fits on, and the drilling happens for the implant depth and location. Because I know my implant location, I can already prefabricate my temp with the right hole position. And when the implants are placed in the patient mouth and the bone have been already scalloped before that, we place the prosthesis and then I pick it up. Now I have a perfectly scalloped bone. I have the right spaces between the prosthesis and the bone, allowing for the tissue to actually grow into the papilla, which is something extremely hard to do.
That's really difficult.
Yeah. In fact, I'm not sure if Byron mentioned to you. Did he mention Lisa?
That she's almost on her final.
Yeah.
Like she's on her final step.
So yeah. So Lisa's treatment was done scalloped.
Oh really?
His treatment was done with a flat. So husband and wife, 2 different treatment for 2 different reasons. She had a lot more teeth that we could salvage the roots and keep them into the bone, allowing for preservation of the bone. Versus him, he had a different situation. So it's not, All-On-4 is not a treatment that you just remove bones, same for everybody, make the same teeth and everything. So all of our teeth are also made custom for the patient faces, which is also another interesting thing that we do here.
Yeah,
yeah,
that's awesome. Huh. Okay, let's see here. If you had, do you personally sit in on many of the consultations when a patient comes in?
Yes.
What would you say if, again, the spirit we're doing this for is for patients that are doing their homework or trying to figure out, A, if this is right for them, B, they're scared, they hate the dentist, they've been hosed, whether it's in their own mind or real in the past. I mean, this sounds highly invasive. Remove all your teeth, and so in that process of remove all your teeth, and I mean, they're scared, right? Let's just cut to that. What would you say are some really good questions to ask of wherever you're going to go? This is to somebody in Seattle that can't come to Atlanta, right? Sure. Or somewhere all around the world that they can't. What would you say is are some good questions to ask during that consultation to help increase their chances of success and lifelong smile ability when they're in that consultation?
A couple of my main points would be to ask how many implants is usually the dentist would even think about planing. We would definitely not go for the All-On-4 process. We would go for the All-On-6 or 8. So if there is an availability of the bone, that's one of the things. So the patient should ask the dentist how many implants do they think they can place. Is there a difference in implant types. Are these implants high quality implants, or are they very cheap implants that are made somewhere we don't know? So there's so many things we have to consider here. Sedation is a big process. They have to ask about if sedation is available, and what kind of sedation does the patient want versus what kind of sedation does the dentist offer. So we have an anesthesiologist here that comes in and take care of the sedation. So we're not in control. The anesthesiologist is, which gives us the peace of mind to focus on what we do. Mm-hmm. Some dentists like to do both. Maybe they're trained for it, but it's more stress. Also, one of the questions I would ask is, the same dentist doing the surgery, is he the same one doing the prosthesis? I prefer to obviously have a surgeon that focus on surgeries, prosthodontist focus on pros, and an anesthesiologist focused on anesthesia. And the reason is, if everybody is a specialist in their field, you'll definitely get a better quality. Not because I'm a specialist and I'm saying that. I know because as a general dentist, when I got out of school, I don't imagine myself just going to a weekend course or few months course and then, okay, I can place implants and all that. Maybe the simple ones, yes. But the more complex cases, definitely a team approach is the way to go. So I would ask, is this being done by a team? Is it an all-inclusive fee? You need to know the fee because you don't want to be surprised. You have to pay this much at one office, then go to the other office. Another really important thing is to ask if your entire treatment is done in the same office or in different offices. Because you might do the surgery in one office, then you have to travel and do the teeth in another office, which, could be a burden on some people, but sometimes it's okay. So, it's very important not to focus on Google reviews, in my opinion. I'm just being honest. Or how much does the doctor post, or how much they show themselves into a lot on their Instagram account and all that. It's really, you have to look at the quality. In my opinion.
How do you know? And I'm with you 100%. How do you know the quality as a patient?
Great question. So as a patient, you should ask the dentist if you can see actual work that they have done.
How? Like pictures of it?
Yes. Before and after photos. Look at the quality of the photos. Look at the quality of how they made the teeth. Ask what kind of zirconia they use, or at least, where is the zirconia made? Is it German-made zirconia? Is it a China-made zirconia? Is it the cheapest zirconia on the market? What's the strength of it, maybe? So these are very technical questions, maybe, but it's like going to buy a car.
Amen.
You ask, does it have airbags? How many miles per gallon does this car make? Or what kind of engine? Do I have a warranty? That's another important question.
Amen.
Is there a warranty on the prosthesis? Do I get a night guard at the end? It's a very important part as well. Every All-On-X treatment that we have in the office gets a night guard, no matter what. It's like your insurance going out of the dealership. That's your insurance to make sure your teeth don't break down in a few years. So there's a lot of questions. If I can sum it up, I would just say, ask the dentist to see actual work, not work from a magazine from another dentist. Because I have noticed in today's society, unfortunately, our office, we don't advertise much because we are word of mouth, because this office is almost 91 years old. So we're well known enough, established, that we don't have to do that. Is it good to advertise? Absolutely. But I have actually seen in social media where people actually advertise with pre-made work by someone else. And it is the world that we live in today.
Right.
So it's very important to ask, is this the work that you have done?
How do you know? Okay, so I go into a dentist's office and all of a sudden I say, hey, let me see some before and afters. They pop out a book. It's all nice and laminated. They start flipping through. How do I know if he pulled those off the internet or he did them himself?
Video testimonials that mentions the doctor and everything. Before video that you see the actual patient before their teeth, and an after video with the same patient with the new teeth, mentioning the doctor and the place that they've had it done in.
Yeah.
I think that's definitely more proof.
It's a great idea.
There's definitely more and more dentists trying to do All-On-X treatments.
A lot more.
Yes.
That shouldn't be doing it.
Yeah, there's a lot more. And, If they want to learn how to do it, sure, go do a 15 months course or something. There is great courses out there, you know, to teach you how to do it. But I don't think after one course, you're a master at it.
Right.
So some patients might get a break in the first few cases that the dentist is doing, because the dentist is telling them, look, it's my first case, I will give you a break, but I will have another surgeon with me making sure everything turns out good. You know, things like that happen,
Sure.
and that's okay if you have another partner dentist.
That's a great point.
So, I think it's important to make sure that this dentist that you're going to has done enough cases, that they feel confident, that they don't rush you from the chair. Big no. That it's not a denture mill or an All-On-4 mill where you just go in, you meet the assistant, you only get 10-15 minutes with the dentist, and that's it. If you feel like the dentist has spent enough time with you, shown you cases, didn't rush you, I think that's a great, indicator of how well this clinic is. Yeah.
Awesome. Well, could we do a little bit of taking a look at the lab?
Let's go. I'll show you around our machines. We have 2 master ceramists. Unfortunately, they're not here at this point. It's almost 8 o'clock.
It's almost 8 o'clock.
So,
why not?
I know. So we actually have 4 people in the lab. Plus myself, I also like to still design all of my cases. So we have 2 ceramists, 2 master ceramists, a lab tech, and a lab designer. So let's go and I'll show you around.
Okay. Thank you, Dr. Tadros.
Let's go. So this is zirconia that actually came from an outside lab, and we noticed their design had some faults in it, meaning the thickness of the connector size was not enough, and it probably had an internal crack before it even came here, because as soon as I screwed it in, it cracked. Now, there's another reason for it that it can crack, is if our impression was not passive enough. So the impression process has to be perfect. We were able to verify that the impression was not the issue, but this might have just had that little bit of internal crack that just started, or the fact that it actually, you can see here, very, very thin connector size. So in these cases, you would have 2 options. You would have to thicken the actual connector, or you would have to remove more bone and make a bigger prosthesis.
So go back into surgery.
Yes, back in surgery, which is not the right thing to do.
Right.
Because it was already planned correctly. So the bite, in this case, the lab actually closed the bite and made the prosthesis thinner. So I'm not really sure why.
Instead of opening it up.
Yes. So in this case, you would open the bite to gain more prosthetic
structural
height.
integrity.
Correct.
Okay. All right. Well, that can happen, and that's good for patients to understand that this is, it's life changing, but it's a little more complex than you think.
Yeah,
right?
It's not as easy as, we're just gonna make you teeth. There's a huge team behind it actually. You have the surgeon, you have the prosthodontist, you have the lab people that are behind the scene that you never sometimes get to meet. In our office, they actually get to meet the ceramist, and they get to explain to the ceramist what colors they want the gum to look like, what colors the teeth they want it to look like, the shapes of the teeth, so we can design that and mill it.
You know, that's a really good point that I want to bring up to you guys. When it comes to the customization of your smile, when it comes to that customization, you really need to take a minute and ask in your consultation, how custom do I get to make this, and what is my interaction with those that are making the prosthesis? Is it, do you just talk to the dentist and he relays the information? Okay, sometimes that can work. Then you need to ask the question, how much time will the dentist himself spend with you? Will he go through books? Will he show you different shades, what BL1, BL2 means, and all the different things like that? So that's a good point. I'm really glad you brought that up, Dr. Tadros.
Yeah, it's very important. So here actually is, we're now in the inside of the best part of the office, in my opinion, because I love the lab. So this is our lab. These are 2 labs combined together. This is the ceramics and the digital portion. So here is the digital portion. We have 1, 2, 3, 4, 5 printers actually. We use these printers to print guides, surgical guides. We use them to print models. Here's a patient that's going to be going through an All-On-4 process. As you can see, they're missing bone and teeth on their right side, lower right side. So we have to figure out how we're going to reconstruct everything. we actually are able to print the teeth, as you can see, and make them look super beautiful. For patients that are interested in something immediate until we are able to get them in implants and teeth that are fixed to the implants, we can actually 3D print the dentures. We can 3D print the teeth, we can 3D print the dentures and combine them together, and it looks absolutely fantastic. So 3D printing has really took us to the next level. In fact, a few days ago, actually, I think last week, or I don't remember, Dr. Tony asked for a surgical guide, and it was the same day. The surgery was the same day. In a matter of 45 minutes, in 15 minutes, we designed the guide, scanned the patient, designed the guide, and in 25 minutes, actually, we were able to print the guide and have it cleaned and everything. So these printers are extremely fast.
That's cool.
From printing, after we prototype, the beauty about printing is we can print many things in prototype. After we prototype this, we take it to the milling machine. Once we mill it, we'll take it to the ceramic. So let me go ahead and show you around the milling machine.
Let's go take a look at that.
So here we are in the milling room. Our milling room is actually, because it's noisy, we're able to just completely close the door when everybody's working. And it's completely ventilated, so all the dust and powders are ventilated. But we have a couple of machines here. We have a 5-axis, simultaneous 5-axis, meaning the puck is able to rotate as the drill is going into it, making absolutely fantastic details for the teeth. This is a whip machine, meaning we mill a lot of PMMA structures, Emax, and all the other ceramic components with it. And then if we have zirconia, we use the Roland DWX. We actually mill our zirconias here as well. You can see it right there. And once we have that milled, we take it into the oven, which it is running right now overnight. We're able to center our zirconias both in this oven and this one as well. And this whole lab actually is run exactly in this office, in this part of the office, meaning we have our own compressor, own vacuum for this portion of the lab.
Self-contained.
Completely self-contained. In case something happens with our machines or our compressor or anything, this can still run and we can still produce and make sure that we have everything for the patient the next day.
Awesome.
Because we have a lot of patients that do fly in and they sometimes expect their teeth the next day, the Temps or something. So we have to be able to do that. But yeah, so it goes from here after we have everything to the ceramic portion. So we'll go there now.
Okay. So now the ceramist part.
So we have 2 master ceramists, Sean and David. Both of them were trained by Dr. McLaren. He's well known around the world. And very few people graduated from underneath of his program. So they're very valuable to us. But we have 2 of them. We have Sean usually is here. And as you can see, all the work is done under a microscope. This here, for example, is a combination case of implants and natural dentition teeth. So a patient does not have to always extract all their teeth for them to just have an All-On-4. Sometimes if we can save teeth, we will actually choose to save teeth because natural teeth is the best option if we can have it. If not, your second best option is implant teeth. Your last option is dentures, which don't really give you that same ability to chew, and the fact that you don't feel the same because you have to cover the palate. With these kind of teeth and with the All-On-4, the palate is not covered, and so much better for the patient chewing abilities and taste. So yeah, but this is where we do all of our ceramics, and they have their own computers because all the shades are taken by them, the shade photos, and all the notes with the patients, and they're able to access all that here. And while they're working, they're able to compare colors and be able to get much better color match.
This is the finish out.
This is
the finish out section, right? So if you were going to describe to the patient what this portion is, this is where you're taking and you're finishing it out. This is where all the detail, the touch, the glaze, the art. This is
the part that patients don't know about. They think the dentist does everything. We don't. We have a whole team behind us. The assistant is just as important as the dentist, is just as important as the ceramist, which is behind the scene. So it's an extremely, it's a huge team approach. A dentist, the best dentist cannot do it by themselves. The best ceramists cannot do it by themselves, because there's great ceramists that will work with a dentist that might not have planned the case at an ideal location, which makes it harder for them. So it's definitely a group and a team effort. So yes, it's really good, and we're blessed in this office to work together and be able to discuss the cases before we go into the patient mouth and actually do the surgeries, because we're able to plan it all outside first. And a lot of times we actually do the planning, printing, and the surgery into the models before we even go in, just to make sure everything is perfect. Yeah.
And you know, for him to have his level of 25 plus years and to work with you guys on the guided on all those different things is just awesome.
Incredible. I would never want an implant in my mouth. Now that I know what it can be and how accurate it can be, I would definitely choose guided surgery. And I definitely think it's going to be the future. We're just ahead of everybody. I think we might be like 4 to 5 years ahead. I think in 5 years, CBCT and implants, guided surgery, will be at least within 60 to 70% of the dentist offices, especially that the price of the 3D printers are going down. And a lot more dentists can now send to the lab to have the guide done, designed, and then printed just in their office. So there's absolutely no shipping involved, which is huge. Is huge. We actually have a lot of dentists that we work with that will send us the planning. We will tweak it, we will adjust it. We will send them back the guide, and they just print it at their office. I'm actually doing a case in Mexico just like that. So because that scalp case that you just saw was actually, it's a case that I'm planning for a doctor in Mexico. So it's really interesting to see other doctors reach out to Dr. Salama and I and ask for our help with planning it, even though we have, no part of it. Like, we've never seen those patients or anything. But we try to...
What a compliment.
Yeah, we try to make it sure that other dentists learn how to do what we do. But yeah, this is the finish line.
Well, that's cool. Dr. Tadros, I really appreciate you taking
so much.
time
Appreciate it.
to spend, educate for patients out there, y'all's heart. Impressive. Thank you
so much.
I really appreciate it.
Thank you.
Thank you.